Welcome. Thanks for coming this morning, bright and early. My name's Tom Evans. I'm the CEO of Eris, and we are a nonprofit biotech that develops tuberculosis vaccines, which I'll talk about in a bit, and how that relates to this talk. I'll try to tie it in. And we have a very interesting panel today. I think that we want to talk about Ebola, what it's done to the economy, how people have responded, and whether this is going to be the changing event of how we respond to such issues in the future, or whether it's just going to be another passing crisis that occurs and, 3 years from now we say, oh, that was interesting when we had Ebola, like, H9N2 or something else. So the panel consists of Michel de Wilde. Michel is a very, very well-known person in the vaccine world. He ran R&D at GSK, then moved over and ran R&D for Sanofi. So he knows a tremendous amount about vaccine development, has actually been responsible for the development of a large number of vaccines, and is now out in the consulting world. Catherine DeLand, who is the Chief of Staff for the Ebola response for the WHO. It's really great to have her here. Obviously has a tremendous experience and can talk about what's happened actually on the ground and the WHO role, and brings sort of that policy perspective. She's a lawyer by training, actually local, went to UCLA, where she did her JD and MPH, so very appropriate that she is here. To my left is Gabrielle Fitzgerald. Gabrielle is going to talk more on the philanthropy, fundraising aspects of, and advocacy aspects of this topic. She has a background, but most recently was at the Bill and Melinda Gates Foundation, ran their global advocacy program, and then moved over to the Paul Allen Foundation and is responsible for their Ebola response team. And then lastly, we have Dr. Shetty, Dr. Pranav Shetty, who is the Global Emergency Health Coordinator for the International Medical Corps, which is also, I found out this morning, located out of LA. It's one of the larger response organizations, and he's going to talk to us about sort of on-the-ground preparedness, disaster response, medical response from the real operational and logistical aspects of that response. So that's the plan for today. And then we would like to be very interactive. We'd love to get questions from the floor. We'd love to get ideas from people and hear people's ideas and comments. So I'll start off with just a few slides. The first one that's up, I hope it's up. No, it's not. Can we put up the first slide? I don't see it.
There we go.
There we go. So just to give people a sense of what's happened from a fundraising perspective of the response to Ebola, it shows what can be done. So there's been about $3.2 billion raised in the Ebola response. And there's outstanding pledges that will take that up to about $4 billion. So this is a huge amount of money that was raised in an extremely short period of time. So the humanitarian funding can be brought together, just like the emergency response can be brought together. So there are a lot of things that could be done right now with $4 billion in terms of diagnostic vaccines and drugs. So I think that's an important point to make. Could you put up slide 3, please? Another important point to make is that when you have health crises, they have very phenomenal impact both on the individual patients, the families, the social structure, but also on the economy. And it's clear that Ebola has devastated the West African economy, both from a tourism point of view, from an infrastructure point of view, from the response, from the disruption to travel, to transportation, everything down the line. And the figures that are put up here are somewhere around $32 billion in the West African economy. And this is a huge amount of money. It may sound like a trivial amount of money in the US, but this is a huge amount of money in terms of these 3 major affected countries in West Africa, Guinea, Sierra Leone, and Liberia. Slide 4, please. And you can see that here. So the GDP of these countries were expected to grow. So Africa has some of the highest GDP growth rates in the world, but these 3 countries are going to essentially have flat growth rates. So not only does it affect the cost to the economy, it's going to affect the growth rates. It's going to slow things down for a long period of time. I think people are probably aware that when HIV hit Africa, the life expectancy dropped by over 5 years. So there was after increase year on year and year from life expectancy decreased. And we're still not back to the peak of life expectancy in Africa where we were prior to the HIV crisis. So these things have true impact, and how long this impact will continue in West Africa, I think, is something we can certainly talk with the panel about. So let's move to slide 8. And slide 8 is going to talk about where these responses are. So the responses to the Ebola crisis and the sources of funds for R&D for neglected diseases tend to come from the same areas. So they tend to come from the public, and that tends to be high-income governments. Although I think people are probably aware that the Chinese actually developed and had a regulatory approval and finished their phase 1 study of an Ebola vaccine in 7 months from start to finish. So it's not just high-income countries that can do this. There's a huge amount of philanthropic money that came in. I mean, both the Paul Allen Foundation, the Gates Foundation, and a variety of other individual donors contributed to the Ebola crisis, although it was still mostly governments. And then the group that has not contributed to any great extent in neglected diseases tends to be the private industry. So either small biopharmaceutical companies or large multinational companies. And I think Michelle will get into that to a certain degree. So where does this R&D money go overall, the money I'm showing you here? And that's shown on slide 9. And right now, and this is in 2010, this has changed a little bit because HIV and AIDS has actually gone up, not down. But HIV/AIDS counts for about 1/3 of all R&D money in neglected disease. TB and malaria account for about 1/6 each. And then everything else is divided up into about 1/3. So things like Ebola or leishmania or other diseases that may come along, different hemorrhagic fevers, are getting almost trivial funding. And we have no true great development of vaccines and diagnostics for those diseases. But despite the Ebola epidemic and the impact it's had on the economy, I think we also need to put it in context. So the context for me is the disease I work on, which is tuberculosis. So if we show slide 13, let's show the deaths from tuberculosis in 2014 and the deaths for Ebola. And you might say, where are the deaths from Ebola? And the reason is the scale is so different that you can barely see Ebola. We're talking about less than 10,000 cases in 2014, 2,000 deaths, compared to 1.5 million deaths from tuberculosis. Tuberculosis has killed 1 billion people in the last 200 years. It's responsible for 1/7 of all deaths in human history. And yet it's an ongoing epidemic. And it is a massive epidemic, and we're doing very little about this epidemic that's ongoing. So more people die of tuberculosis in 2.5 days than have died of all Ebola and all Ebola cases combined in 2.5 days, a person every 21 seconds. But we won't talk about that because that's just that disease that's been around for 70,000 years, and who really cares, right? And, and plus you can treat it, right? So can you put up the next slide? Except there is extensively drug-resistant tuberculosis, which is not spread by contact. It's spread by air. It's got airborne transmission. The mortality rate in the literature for XDR-TB is between 30 and 70%. It's the same mortality rate as Ebola. There were twice as many cases last year of XDR-TB as there were of Ebola. Yet how many people in this room really think about XDR-TB as being an ongoing crisis? So Ebola has been a crisis that we really need to deal with. On the other hand, we're having ongoing crises all the time in global health that we're not addressing at all. So that's to put this in context. And I'd like to start off by turning to Catherine, who's going to talk a little bit about the WHO, talk about the policy, what happened in the crisis, where we are, what went well, what didn't go well, what lessons have we learned, and where should we be thinking about going? So Catherine.
First, hi, thanks so much for inviting WHO and me to be here today. It's a real pleasure. If I could have slide 25, that would be great. So when we talk about where we are, and it may be really useful to look at where we've been as well, these charts show the entire outbreak from beginning to end. So it starts in the beginning of January 2014 and moves through April 2015. And as you can see, as you get towards the end of 2014, we have massive peaks. And I couldn't agree more that TB is certainly killing more people per day. But there were times in the middle of this where it was a scary moment. 400 and 500 Ebola deaths or Ebola cases per week was something we'd never seen before. We had outbreaks in the past where the total outbreak would be 200 people. So 200 cases. So this was an extraordinary thing. And I think perhaps one of the reasons that this is treated differently than is something like tuberculosis is that when we see a disease that we haven't seen before in a new place, that is something that requires attention, that we should be paying attention to. And in this case, the Ebola had been seen. There had been one case in the literature earlier, many years earlier. This is the first time we'd really seen it in West Africa. So perhaps most importantly, in terms of where we are now, is to look at the far end of those graphs. We have about 30 to 40 cases per week right now. We haven't seen a case in Liberia for almost the requisite 42 days. 42 days will be on May 9th, provided there isn't a new case. So Liberia is nearing what we hope to be, we can declare the end of the outbreak there. Sierra Leone and Guinea are in slightly different places. However, if I could have slide 28, I think it's really important when we talk about Liberia being close to done and we talk about Guinea and Sierra Leone, to think about what has worked. And so look at the curve here, and I understand that the date here says the 19th of January 2015, but actually pushes out to about March at the end of that. And I think over the course of the largest part of the outbreak, the response that we really had, and I look to my colleagues also from the International Medical Corps who are certainly part of this, was to increase the number of burial teams substantially, increase the number of beds, treatment beds and isolation beds, and to encourage behavior change. So we talk all the time about Ebola in terms of how sort of scary it is. But I think one of the things that I learned from being in the countries and seeing people do this is that it's also incredibly difficult to be a family or be a human being around this disease, because the one thing you can't do is comfort the people in your family who have it. When it is the most dangerous is when you want to be most present to help your family. And so one of the things we had to encourage was a fundamental behavior change in this community of people, where you really couldn't go and hug your children if they were sick. You couldn't go and hug your relatives. So the things that worked were increasing safe and dignified burial, were getting people isolated, getting them out of the house early enough that they weren't infecting their other family members, and then encouraging people not to touch each other, really. Could I have slide 29? So now we're in a different phase. We have enough beds, we have enough burial teams, and really behavior has changed, though there is some, we're calling it Ebola fatigue. There are some people who believe they now know how to manage Ebola, and so it's okay to get 5 people into a cab, or it's okay to hold hands walking down the street. And in some places it probably is, but in places where there's active transmission, we have to be careful. So now we've shifted into the next phase, really, of this response, which is to allow communities to feel real ownership of the response and to do really aggressive case finding and contact tracing. Every single case, if you have every single case coming off a contact list, then you're essentially 21 days away from having there be no more Ebola, right? So just to back up and explain what that means, if you have a confirmed case and you can trace all of the people that this person has been in contact with, and then all the cases come off of that list, then you can follow that chain of transmission. What's more concerning is when you see a death in a community that hasn't come from a known chain of transmission, because it means there may be other hidden cases out there. So case finding, contact tracing, community ownership, those are the things that are working now, and that's how we're really going to get to zero. If I could have slide 24, this is my last slide. Just as an overview of the policy side of where we're going, there's been a couple of big meetings lately. The spring meetings, the World Bank spring meetings, were really focused on recovery, post-Ebola recovery. And this is the WHO, and I would say arguably the international community's current plan for moving forward in terms of the Ebola crisis. We really need to focus on the response. Our #1 priority has to be getting to zero. And I cannot emphasize enough how this is going to require something that public health doesn't often require, which is programmatic perfection. In public health, we're often very satisfied to reach a 90% coverage rate. And here, really, it has to be 100%. This started with one case, it's going to end with no cases. That's how we're going to reach that. And programmatic perfection is an incredibly rigorous standard. At the same time, though, we need to be talking about early recovery. And early recovery, in terms of priorities, needs to be providing people with access to essential services, opening schools, vaccinating kids, getting programs that are active and possible so people can go to the doctor for primary care. And that's really going to take through the end of this year. And then we need to focus as an international community, as WHO, as our partners, on health systems development, on really providing these countries and all fragile economies, all fragile health systems with the opportunity to be robust enough to respond more effectively in the future. So what's worked has been the initial response of building beds, isolating people, changing behavior. And what's working now, as I said, is contact tracing, case finding, and community ownership. The question of what didn't work, I would arguably, the world was slow in responding to this. I think that the lesson, as I said, of seeing a new disease in or an old disease in a new place is something that we all need to pay more attention to and react to more strongly in the future. I think that the UN, for the first time in its history, established a mission for public health. Usually the missions in the UN are for conflict, they're peacekeeping missions. So this is the first UN mission in history on public health, the emergency Ebola response. And I think that was very successful, but to have to do that, to have to call in the UN instead of more traditional constructs for coordination means that there was a lack of coordination at the beginning, and we had to bring in a new model. Now, it may be that that new model teaches us lessons that we want to use again, but it does mean that at the very beginning there were things that were not necessarily working as well as they could have. And I think the last lesson is one that's just really, I mean, I think there's more lessons than this, but for me, as a person who's spent quite a lot of time in West Africa, I think the part of the lesson ties into what you were saying earlier, is that we need to start paying more attention as internationalists, as a global community, to these places that desperately need help. These are the poorest people in some of the poorest places, and the first thing that we did when this happened was isolate them. No trade, no airplanes, no in and out. That was our first response, and that can't be how we respond to these things. We have to be more responsible as an international community to take care of everybody, and that's how we take care of ourselves. I'll stop there.
Thanks, fantastic comments. So I'd like to turn to Dr. Shetty, and who's basically seen on the ground how prepared we were and how we went in, we meaning the global community. So why don't you talk a little bit about the operational aspects of sort of emergency relief, how we prepare, what went right here, what went wrong, and what this teaches us about the future from more of the operational aspect as opposed to the policy aspect.
Sure, great, thanks. And thanks again for the invitation to the Milken Institute, and it's a pleasure to be on this panel. Just as an introduction, work for International Medical Corps, as you mentioned, based right here in Los Angeles. And in fact, our CEO, Nancy Ossie, is here with us today. And in general, we're a global first responder, and one of our specialties are health crises and emergencies. So along with Ebola that's been going on now for 9 months, that we're responding to a lot of, along with the humanitarian community in general, responding in Yemen and Nepal, of course the earthquake in Nepal, Niger, and things like this. But as you mentioned, Ebola operationally was a particular challenge for us, and I think at the heart of that was that we didn't have the tools required to deal with that challenge. If we have a measles outbreak somewhere, we have a vaccine that we can use against that outbreak. We have a framework around which we can structure a response for this type of outbreak, but that didn't exist for Ebola. It was something that was new, it was invisible, and I think that was what drove a lot of the progress actually over the last 9 months. Was, as you mentioned, TB is huge compared to Ebola, but the perception and the fear around Ebola was actually very pertinent in terms of getting resources behind this particular outbreak. In general, the mantra for public health response is early detection, early response, and early detection is a local phenomenon. So it's something that if we don't strengthen health systems at the local level, you will never get to the stage where we can respond effectively as a national or international community. So as was mentioned, when Ebola started in Guinea in December of 2013, nobody knew about it until March. So it stewed for 3 months in Guinea without any sort of recognition in the outside world or even in the country, so to speak. So, one of the priorities for public health preparedness, as you mentioned, is really addressing this issue, is addressing kind of national health systems and getting the framework in place for them to be able to detect the disease and provide the initial response. And on top of that, there's a need, obviously, for a strengthened international response. As Catherine alluded to, this required a paradigm shift in the way that the international community responded to Ebola. It required the formation of a new organization to be able to do so. And it just shows our lack of preparedness globally for something like this. And that's actually very important to consider because there's a lot of lessons learned that come from, into an international community from that very aspect. And, global health security is a shared vulnerability. So we need to have a shared responsibility, to address it. And if we don't change the way that we address some of these issues, in general, before they come onto the world stage, as Ebola did, we're always going to be surprised and we're always going to be caught off guard. But operationally, just as you mentioned, so I spent about 8 months between the 3 countries, Liberia, Sierra Leone, and Guinea, and we were operating 4 Ebola treatment units, at that time. And we started ours relatively early on. It was in August that we started moving, and we started treating our first patients in September of 2014. And at that time, the dynamic in country was literally one of confusion. And I think there was the country itself, Liberia, Sierra Leone, Guinea have very weak health systems. So they're not prepared to deal with issues that occur there on a daily basis, let alone such a shock to the system, such as an Ebola crisis. And so it took essentially a reworking of the whole kind of response framework or model that they use to kind of create this. So at the same time that we're trying to address this terrible disease, we're trying to create a system that's designed to address the terrible disease, and that's not something that, that can happen. And I think, honestly, in terms of lessons learned, that's one of the greatest lessons that we learned, is that if we don't have a framework in place to detect and respond to disease, normally we'll never be able to respond to something like this, and it's going to be a huge issue. One of the other things, actually, for Ebola specifically is, as Catherine mentioned, this is the longest, largest, deadliest Ebola outbreak of all time. It's also the first time Ebola traveled in a plane to another location. And that's enormous, and I think, and it kind of highlights the deficiencies that we have in public health preparedness on a global scale. We saw the same thing in SARS. In 2003, SARS was traveled on a plane from Hong Kong to Toronto and Canada, at that time. But even if we realize that, we can't stop all the planes, we can't, shut down global trade and the global economy, if we can strengthen health systems in the areas, that receive a lot of these affected cases, we'll be able to have a more concerted and a better response and really prevention at the first stage. So, for example, in SARS, there's a patient that went from Hong Kong to Toronto. That led to over 240 cases of secondary transmission and over 40 deaths. On the same day, there's a patient that went from Hong Kong to Vancouver, which resulted in 1 additional case and 0 deaths. And it just shows you kind of the difference that can occur in the system. So it happened to be that Vancouver was just much more prepared. They were much more kind of resourced to be able to deal with an infectious disease with an unknown source. And so the patient was isolated, they put respiratory precautions, and they diagnosed the disease, and everything was okay. But in Toronto, that system wasn't in place. And it's not something about the specific hospital or the doctor or the nurses, but it's systematically how they're prepared to deal with this type of response. So in Ebola, as you mentioned, this is something that's new relatively on this type of scale. It's scary. It has a high case fatality rate. All of these issues really spurned a lot of this initial response. And so And honestly, the response, as we know, came slow in the beginning. We're talking about an international framework for about how to deal with these type of issues, and really it needs to be faster. I mean, that's what we've learned. As Catherine alluded to, a lot of the pillars of Ebola response, contact tracing and surveillance, safe burials, isolation, really are the things that shifted the curve downwards in terms of the epidemic curve for Ebola. But we were late in doing so. There was a huge US government response, to Ebola with, the military, a lot of construction and things like this. And it's hard to tease out really which elements really helped to bring down the outbreak. But you can always make the argument that should have been done sooner. It should have been activated sooner. There should have been a coordinated mechanism to allow for this type of response to happen in the early stages rather than the late stages. And then we're always being reactive and we're always trying to catch up. And even now, as Catherine mentioned, we're trying to catch up to that last 5%, which is the hardest to get in any outbreak. And it's this sort of issue that if we could have responded quickly, more quickly and in a kind of a larger scale earlier, then maybe we wouldn't be having this conversation at this time. So I think, this has really highlighted a lot of the gaps that exist within our international public health system, both at a local level and a global level. And there are a lot of lessons to be learned from that around health system strengthening and an international framework to deal with these type of diseases.
Thanks. So I'm going to turn to Michelle. And so there were drugs and vaccines that had been tested on Ebola, actually as much as 10 years ago. And yet when the crisis hit, there were enough supplies to treat maybe 3 people with the drugs, and no vaccines were available that had actually gone into phase 1. And so we completely were unprepared from a tools point of view, despite the fact that we could have been prepared. And now the vaccines, as people probably know, are all being tested, but there aren't enough patients now to actually find out whether they're efficacious. And so why don't you talk to us about, why is that? What's happening in sort of the vaccine drug diagnostic world? And then what went right in Ebola, and what does it teach us about the future in terms of drug diagnostics and vaccines?
All right, so quite an agenda. But indeed, it's a very fair question, and especially addressed to the industry, assuming I'm representing the industry here. And as Pranav rightly pointed out, if there had been a vaccine, things would have been just completely different, and this panel probably wouldn't even meet, right? So why is it that there is no vaccine against Ebola for a virus that's relatively straightforward? So it's not a virus that mutates like HIV or evolves like continuously like flu. So the static virus is a very aggressive virus. It was discovered in 1976, so almost 40 years ago. So why is it? So thinking about that, I thought I would address that through driving you quickly through the actual development pathway of value chain for a vaccine, if I can have slide 16, on which I start the illustration to use a panel on the right from the Partner for Appropriate Technologies of Health, an NGO that's mostly active in neglected infectious diseases, etc. So I thought I would use that panel to avoid any bias in the description of the value chain, which is indeed very long, and I'll come to that in a minute, but also it's a very expensive endeavor. In past estimation here, 5 to 100 to $1 billion US dollar just to develop one single vaccine, one straight development pathway, let alone multiple approaches to it. This is probably on the high side of the estimate, even from my own personal experience, the last of which in the industry was the development of a dengue vaccine that's now undergoing licensing, is indeed close to this 1 billion framework. So an enormous investment for an enterprise that has high risk, right? So there is risk at every step of the way. The so-called attrition rate is less than for drugs, right? So there are less vaccine that falls on the wayside. But you have to balance that with the fact that all the targets that are really straightforward have been dealt with. So the new targets have high scientific challenges, and we can argue where Ebola falls in that. Another very important aspect of this, and it's represented by those little dollar signs here on the right, is that there is this major outlay of money occurs late in the process, right? So you have to have some serious, very serious incentive to make that step, right? And this is referred to also for drug development as the valley of death, right? Because compounds or products sit there at the end of preclinical or phase 1, and then you have to take this huge step of making the product in large quantity, preparing for manufacturing, etc. And at that moment, there is a prioritization exercise, and you decide which are the targets you go for and which you let on the shelf in a way, right? And this in overall context for the industry of raising standards, both in manufacturing, regulatory, etc. The next slide, so 17, looks at the timing aspect of things, right? So it's a very long process. Takes a number of years in what we call the exploratory phase, and you can see for yourself how long it takes, let's say 10 years. And I've highlighted some characteristics here as well. So the exploratory or the discovery phase is extremely rarely done within big pharma, right? It's always done, invariably starts in academia, then moves to a biotech stage, and then the biotechs usually don't have their own financial capability to go through the valley of death, so that's where partnership happens, and they are either acquired or make a deal with a company. And this is certainly true for Ebola. There's a 3 vaccines that are, let's say, the most advanced, all have their origin in academia and biotech. So the GSK vaccine comes from the acquisition of Ocarius, a biotech company in Switzerland, if I'm not mistaken. Italy, sorry. And of course, the acquisition was not driven by having an Ebola vaccine in the pipeline, another vaccine. So that vaccine was sitting there on the shelf. J&J is similar scenario through the acquisition of a Dutch biotech called Crucel, who had run some experiments and had a candidate vaccine also developed in part with NIH, and then another approach, which is Merck, who in face of the crisis decided to react extraordinarily rapidly, made a deal with GenLink, is the company coming, it's a Canadian research effort. Within 1 month, they closed the deal with them and moved into the race, right? So it's the first sign that everything is different or has been different for Ebola. The second right part of the slide explains how traditionally this is a very slow process, takes clinical development, takes anywhere, depending on your target, the schedule and what it is, etc., etc. But easily, let's say 5 years in general or whatever. And then the registration process itself takes about a year to assemble your file, and let's say 18 months for the most aggressive agencies to actually register the vaccine. So if we now move, so as much as the first part, the left part is correct for Ebola, the right part is completely different. So what happened there has nothing to do. So if we can move to 22, you can see that this entire step trajectory from phase 1 to phase 3 and eventually registration, hopefully, will be concluded in 18 months. So absolutely extraordinary, and we can discuss in the panel of what happened, why that is, or each actor in this value chain actually intervened to make things very, very different that they were done traditionally. So on that point, I think I will stop and wait for the discussion later on.
I think we'll come back to some of those points. And so let's turn to Gabrielle. And you've been involved in trying to figure out how to use money to respond to the crisis and how to interact with other groups that were responding. Talk to us about the what philanthropists can do, what worked, what didn't work, how, and then is this going to be sustainable? In other words, a year from now when the WHO has stamped out the last case and sort of there's the new flu crisis or the new SARS crisis or MERS or whatever it is, is your job gone and now you're not going to be the Ebola response crisis person, but you're going to be something else? So tell us how it's been in the philanthropy world to deal with the Ebola crisis and getting in probably a little bit, as everybody else did, a little late to the scene.
Yeah. Well, thank you. Great question, and glad to be here, and thanks to Milken for this panel. So I first want to start with TB, because as you mentioned earlier, I spent 10 years at the Gates Foundation, and one of the things that we tried to do there was bring in other partners and stakeholders to the diseases that we were working on, so TB, malaria, leishmaniasis, things that are not usually talked about. And it was really hard, particularly on TB. We did a little better on malaria. So fast forward to Ebola. It was so, while the world was slow to respond, when the world did respond, there was suddenly this outpouring of support from a range of new actors and stakeholders, including philanthropists. And I think that's really interesting, and there's a lot of lessons learned efforts going on about the Ebola response, and that's one of the pieces that I'm particularly interested in. So Paul Allen is a longtime philanthropist, but who had never been engaged in global health before. He became aware and interested in Ebola because his philanthropic interest was in wildlife conservation. And about 5 years ago, he had funded research into Ebola in primates. And so I think because of that, he had an early awareness and started asking his team, is there something we can do to help? Now, this is in the July-August timeframe, which is still quite late compared to when the epidemic started, but much earlier than many of the other philanthropists or global organizations. So then fast forward to the fall, Paul Allen announced that he'd provide $100 million to support the Ebola response. And it was really seen by a number of other philanthropists as a wake-up call or call to action that more needed to be done. And while I hate to use the word exciting in the same sentence as Ebola, there is something exciting about the number of people that came to the table to work on Ebola. And so in addition to Paul Allen coming brand new to global health, we saw Mark Zuckerberg make a large donation, and a number of other Silicon Valley entrepreneurs come in with financial commitments, but also commitments of their resources to try and solve the Ebola problem. And so there were some really good results of that, of people getting money in and being able to flexibly respond with that funding. But there was also some downsides where people really wanted to contribute either financially or with talent and didn't know where to turn. And so I think one of the lessons learned of this is that we need to think better about how you create some sort of matchmaking or clearinghouse to let people engage more quickly and more easily when they want to. Because the last thing that we all want as people that care about global health and about development is for people to feel like they're not needed, that they're not welcome at the table because they haven't done that before. And so I think, sadly, there's a long list of gaps, and that's another one that we need to think about. So one thing that we did last week in San Francisco, we hosted what was called an Ebola Innovation Summit, where we tried to bring a range of those people to the table to try and encourage them that both this Ebola epidemic's not over, and there are many things to be done to prepare for the next epidemic, whether it's Ebola or something else. And we need your financial resources and human resources and talent to come in to help solve those problems. And so we got a really positive response about bringing different people together, people from the global health community, from the entrepreneur and innovator communities, and really getting them to talk to each other and work together because, as we were saying last week, it takes 21st century solutions to solve 21st century problems. And as we've been hearing about over the course of this conference, the world is so different today than it was a couple decades ago, and it's going to be different in the future. And public health and global health need to keep responding in a modern way and not rely on some of the tools and technologies we've used in the past. So let me stop there, and I'm happy to discuss further.
So let me follow that up with a question. I'll pose it to you and also to the panel, but I think Catherine and Michelle. So say you're successful and we get $1 billion donated to develop the tools that Dr. Shetty talked about, the tools we're going to need for hemorrhagic fever or for Lassa or for XDR-TB or whatever it is. And that pool comes in, there's $1 billion. Who and how are we going to prioritize where we're going to use that in terms of this global response to the next epidemic? So we get $1 billion, we get $2 billion, we get $3 billion. Is it health systems? Is it the diagnostics? Is it the drugs? Is it preparing volunteers to respond? How are we going to do that? So at the Gates Foundation, how did you do it? And how would you do it now if you were in charge?
Well, I think a really interesting thing about philanthropy is that philanthropists get to make that prioritization based on their own criteria. And so I think those of us that are health professionals or care about development, it's really making sure that education and information is out there to help philanthropists choose wisely. And I think we haven't seen much success in raising billion-dollar funds, but what we have seen success in is getting people to contribute based on their individual skill sets. And so it's really harnessing people's energy, interests, and talent to make progress toward reaching some of these goals.
Michelle, how would you prioritize?
I think it's quite a challenging question because there are so many things we know out there and maybe some we don't quite yet know. So there are, for the sake of discussion, let's say 100 microbes out there, the threat to disease, and less than 30 vaccine available to treat for. I mean, for less than 30 of them, do we have a vaccine? So, how do you deal with the others? In between those that are still serious problems unresolved. I didn't actually ask for this slide, but it's interesting that it's there. It illustrates a number of points. There are many measures or way to try to gauge the activities, but this is just a slide, data taken from a site which is called clinicaltrial.gov, where everybody who runs clinical trials is mandated to list his trials. So this is just a list of trials being conducted today. And from that slide, you can see that you could consider that HIV, malaria, and TB are no more neglected, which, of course, I'm is going to argue against. But by this criteria, there is a lot going on. But it's also probably a reflection that how little we understand, so that we do all those repetitive trials. And since they are the recognized big three, there is enough funding for them. In the little bar at the end, where Ebola sits among probably 60 others, you have leishmaniasis, right? That I think you mentioned. I happen to be sitting on the board of an interesting biotech company, which is a non-for-profit biotech company. There are not few of them. It's called Infectious Disease Research Institute, which is actually the leading leishmania vaccine candidate. It's not far along, and the whole enterprise is at risk of finding the funding, by the way. So, but so I think it has to be an international community who drives or determine priorities, but it's very challenging, and probably maybe WHO would be an appropriate setting to do that or to discuss that. But I'd like to take this question from another angle, if I may, by looking at slide 18, which is, we don't know what's next. We know for sure, guarantee, there will be another flu pandemic of some kind. It's just a matter of figuring out which one. And the research for pre-pandemic vaccine or universal influenza vaccine is going, has a lot of steam, but it's extremely challenging scientifically. But I'm personally very hopeful, and I see that one approach is if we can sort of make vaccine development in modules, or more reproducible. And there are out there new technologies, which we're talking about 21st century, that give me a lot of hope, right? The way we currently discover vaccine is completely different, right? And everybody has heard about genomics and many other omics and metabolomics and proteomics and et cetera, et cetera. But behind this catch-up world, this is a lot of science, which now combined with the power of big data analysis and the fact that of what we now call synthetic biology, where we actually synthesize almost biologicals almost chemically, will have if it really works and pans out, will have a drastic impact on both the discovery phase, but also the development phase, in the sense that we will be able to standardize and make modular manufacturing. Yeah? Today we have to make this gigantic investment product by product, and here we would have a way to use the same machine, just change the gene sequence, which we can do in a day or so, and get going with making the product, also at a very reduced cost. On the regulatory side, it was already alluded to that probably we won't be able to see if the current vaccine candidate work, because fortunately the epidemic will be dealt with. So we're forced to reverse, and regulatory authorities are open to that, to an approach which was actually designed for bio-threat situation, right? Who by definition you don't have yet the pathogen out there, which is called the animal rule. So we would get licensure on the fact of preclinical efficacy, if you wish, and this would go together with then post-marketing commitments, probably even in more serious. But my message here is that I think from the technology point of view, I see great hope of making those things more efficacious.
So, Catherine, Bill Gates wrote an editorial. It was in the New England Journal, and I think said a lot of things the panel's saying, which is that we need an institution that's going to coordinate the next response, the next crisis. It needs authority. You need to invest in tools. You have to do R&D. It needs fast decision making. You need to put in the early warning and detection systems. We need to strengthen the health systems, and we need to do, as a laboratory person, you always need to try things out first. So you need to do preparedness exercises. The military does, NATO, the Russians, Chinese, they all do exercises to make sure things work. So who's going to do that? So are you going to do it? Is the WHO going to do it? Is the UN going to do it? Is there a new organization that needs to be created among the world group? Is the G7 going to do it? Is the G20 going to do it? Are you going to do it? So who's going to do this?
So it's such a good question. I think the first part of the answer is nobody's going to do it alone. But this is a global community effort that's going to have to be undertaken. However, from a WHO perspective, organizationally, this is, again, I hesitate to use the word exciting in the context of Ebola, but it is one of the most exciting times that I've been through in 16 years of being in the organization. I think the organization sees the need and is ready to become the organization that is needed to do this coordinative, very engaged operational kind of work. And we have the political leadership and we have the member state support to do that now. So for instance, very recently, our global policy group, which is our director general and our 6 elected regional directors, released a statement saying that there were a number of actions they were going to take. And maybe we can use one of them as a great example of this being maybe led by WHO, which I think we are well positioned to do, but certainly a joint effort. So a global health emergency workforce is being contemplated. And the idea there is certainly that WHO itself would have standing and surge capacity, so enough people to respond, say, to the first 30 days of an emergency. But the larger part of that would be to activate a bigger network, activate our member state governments, activate academia, activate the cluster, global health cluster, activate our partners like International Medical Corps, like MSF, make sure that everybody is coordinated and responding. And the global health workforce then would be on call and present. Part of that clearly is training. Part of that clearly is doing scenarios, is all of these things. But it is a very active conversation that our Health Assembly, which is meeting next month, is ready to take up, and that our member states are very keen to think about. Our executive board discussed this in January, so it's a topic of great interest. I think similarly, though, if we are going to be doing those sorts of things, and I think this speaks to Gabrielle's point nicely, is this is going to require something of a sea change in terms of how we look at funding and how we look at the availability of resources, both in kind, so people's expertise, money itself, infrastructure, and everything else. As the number one thing we can do to be ready for this is have countries be ready. So if we really want to be prepared for the next outbreak of whatever kind, what we do first and most and best is invest in country health systems. Make sure that the people are on the ground to respond and be present to that. And the way we do that is by drawing on the expertise that's available in the world, ours, to really build in those places that are most vulnerable, but also here, also everywhere. There should be, everywhere should be ready to respond to something. I mean, the difference between Vancouver and Toronto in a place that, I mean, Canada isn't West Africa. Canada is here, and it's not a place that you would think of having such large differentials in terms of preparedness across two cities, but there it was. So I think the focus there.
So what about the skeptics like me who say WHO never gets anything done, they're a bureaucratic organization, things go there, it gets into a morass, and people sit around and just discuss things for years and months and days, and then nothing, and then a policy comes out, but nothing really happens. So why would we put this in the hands of WHO if it's that important? Just to push back on you a little bit.
No, of course, welcome to push back. I'd like to put up slide 33.
Oh, she's got a slide for me.
So this is just something to point out what WHO has done. I think that it's been very easy to talk about, in the media in particular, has been quite keen to talk about what the UN and the international system hasn't done. But we right now have 800 people in the field across 63 active sites. Just as a point of interest, normally an emergency response has 3 or 4, maybe 5 active sites. So we have 63 active sites, 800 people in the field. We've worked with multiple partners. We have 200, I mean, there's been 2,000 technical experts out there, 1.4 million personal protective equipment kits. And let me tell you, this was not a small effort. This involved numbers of people and getting the right people in the right places. So although WHO traditionally has, and I would say the economic crisis of the last 10 or 15 years has hit the organization particularly hard, has not been seen as a necessarily very operational responsive organization. Even in the middle of that, we've managed to respond in this sort of way. Even in the middle of that, we've worked with our partners and fielded people, and we're down to 30 cases a week from upwards of 500 at one point. So arguably, even today, we are doing the right thing. Now imagine if we were capacitated. Imagine if there had been a focus on WHO being operational. Imagine if we had the money, the resources, and the structure to do that. And I firmly believe, I genuinely can't, I absolutely believe this, that it is the time and the place and the politics. Remember, we're a member state-driven organization. I have 194 constituents that I answer to. And at this point, I think that all 194 of them are ready to come together to make some changes. And I think that they are ready to hear us say that we're ready to do that. So I'm very optimistic.
So Gabrielle, I'll ask one more question, then we'll turn it over to the audience, so think about your questions. So the 25% of the GDP in the world is driven by the BRICS countries. And so getting them involved in committing to TB or malaria or HIV has been very difficult. Do you see them now so do you see them being responsive from your point of view? Were they at this innovation forum? Did you see Brazil there? Was China there? China, or are they just going to do it on their own, and as they've tended to do with other things? Is India going to be there? Is Russia going to? So what about the BRICS countries in this?
Yeah, so great question. So one of the things that I found so interesting about this Ebola response, and to give the UN credit in this new emergency operation they stand up, is that the UN Ebola envoy convenes a weekly conference call. And there are at least 50 entities participating on that. And so I participate from my philanthropic lens. But what's really, really noticeable is the number of countries around the world that are participating. And so there's, of course, the countries that are affected. There are the donor countries, and then China participates. And when I was in Monrovia in January, there was the daily incident management committee meeting, and the Chinese military was there at the table with the U.S. military. So I think that's really symbolic of how much the world has changed and that these players are engaged in some of these solutions. I think there's room for more. One of the initiatives that I was responsible for at the Gates Foundation was some of building emerging market partnerships. And one of the ones that I was involved in that I think has had tremendous potential was partnering with the United Arab Emirates on some vaccination campaigns. And not only do they bring financial resources, but they bring credibility to issues that sometimes a Western entity or a Western government might not in parts of the world where the US or a US institution may not be welcome. So I think, to your point, these solutions need to be truly global, involving the BRICS countries, involving really all countries in the solutions at this point in time. And it really can't be, well, the G7 will be critical in driving it, and the UN agencies will be critical. It really needs to be a holistic global community that's responding to making these changes.
Good. Do we have questions from the audience? So please go to the mic in the center, and you can just line up there, or you'll get a mic passed around. It's hard to see you because of the lights, so you're going to have to sort of go to the mic and stand in line. But we'll start here.
Okay, thank you. Great conversation. Just like to circle back to the resources and the needs ahead. So the Ebola response from a resource perspective was slow, and then USAID's Office of Foreign Disaster Assistance, Mark Zuckerberg, Facebook, Paul Allen, Bill and Melinda Gates, a lot of people kicked in. But we've still come back to the fundamental issue of the lack of global healthcare workers around the world. So WHO estimates it around 7.2 million. Over the next 20 years, you think that's going to double. This goes to the response and preparedness, the prevention piece. How realistic is it that the funding flows, as well as the will of the international community and local governments, how realistic is it that they're really going to address that issue, which is having health workers at the ground in these communities to deal with all the kinds of threats that we're talking about?
Well, Catherine, why don't you start off with that one?
So to take off my WHO hat for a moment and sort of put on my global health governance hat for a moment, I think traditionally health has been one of the governmental sectors that has been sort of underappreciated. You know, where governments really look to first has often been defense and revenue and foreign affairs, and health can be sometimes considered less important or relegated to other space. And I think we have a moment in time here where there may be an opportunity to have health be considered on a similar footing, if not forever, at least for the moment, as in these other spaces. And I think the opportunity then, as a global health diplomat, as a global health worker, as anybody who's involved in this, is to figure out how to institutionalize that. So one of the mechanisms we're looking at, just in terms of surge capacity, is to have things like contingency funds available. The World Bank is looking at a pandemic emergency fund that they would use to, in fact, activate and mobilize global health emergency workforce teams. I couldn't agree more that the question of sustainability is one of the things that we need to be most conscious of. And part of that is going to be subject to the political ebb and flow. But I think we have a chance here, if we're strategic and thoughtful, to institutionalize some of these pieces to provide the kind of support that we need. I think that evidenced by the fact that also the philanthropic communities are deeply involved in this and will probably continue to be deeply involved. Again, I think we have to be smart. I think that's part of the answer, is to be strategic and thoughtful right now in this particular moment.
So Gabrielle, why don't we just put a $1 tax on every plane flight, because these things travel by planes, and you know, there's something like 10 million passengers a day. We get $10 million a day. So
Well, I think
it's a dollar nobody didn't even notice because people that can fly planes, you know, have
well,
you know?
we have seen that done with
Yeah.
France and Brazil and the Unitaid Fund, and so I think that's certainly an option. And I think looking at creative, innovative financing mechanisms is an important thing. But just to build on what Catherine said, I think we really are at risk of the world moving on. I even have people say, "Oh, you're still working on Ebola? Isn't that over?" And I explained to them that no, we're at exactly the same point we were a year ago. And you know, look what happened in the fall when we didn't take care of it. So when I was in Davos in January, Jeremy Farrar of the Wellcome Trust was reading a set of recommendations that the world needed to change. And then he ended his statement by saying, okay, that was from the 2004 Institute of Medicine report. I believe it was in response to SARS. And so I think the challenge for us today is to not just kind of document the lessons learned and make a nice report, but really to make sure that we take action on them. And you know, the strongest lesson learned is that we've had these lessons learned before, and we need to make sure it's different this time.
Question, please.
Thank you so much for all of your comments. My question is about the hundreds of healthcare workers in these communities who've died over the course of this outbreak. Is anybody looking at the impact of that lost human capacity, and any personal thoughts on what we might collectively owe their families in a way? Is there some sort of legacy here? I know it's not necessarily structural, but just this is a big hole left in a lot of these communities, and how do you reflect on that at this point in the outbreak?
Dr. Shetty, why don't we start with you?
Sure. Did
you maybe personally know people that came down with the disease? Did you have any of your workers, or were you, I wouldn't say lucky, were you appropriate and you didn't come down with, and you did use the appropriate controls? So.
No, definitely. Thank you for the question. So we have seen that health workers particularly were vulnerable to this disease because they are the ones that are caring for the patients. Unfortunately, in the beginning of this outbreak, they didn't have the resources required to do that job. And we're not talking about even vaccines or, you know, kind of complicated systems here. We're talking about gloves and masks or protocols that necessitate the routines and behaviors that are required when interacting with patients with a hemorrhagic fever or any sort of infectious disease. International Medical Corps, we, as you mentioned, through preparedness and maybe even fortuitously, have not had any health worker who has been infected among our staff, but we have had patients who were health workers in surrounding hospitals that we've treated and have died, throughout this, and some of them have survived. And actually, we have recruited those staff to actually work within our center as survivors because they are the best advocates for the center, and what it can do. I mean, in Liberia before, there were 50 doctors for almost 5 million people. And a lot of those physicians were actually in administrative positions. They weren't actually in the communities treating patients and things like this. So, at the end of the day, we've seen that this, and alluding to what was mentioned before, the health worker shortage is, when you lose health workers, it's so massively magnified in a place like West Africa. Because those are the health workers that are required to address this disease and every other disease. I mean, we're talking about investments in health systems and innovation and addressing, some of these neglected diseases. But some of the neglected diseases have tools, have treatments. Schistosomiasis has a very cheap treatment. Roundworm and ascariasis has a very cheap treatment. Dengue, we know how to do vector control. And so perhaps it's, one of the components of this is this health worker gap. It is because we don't have enough health workers to diagnose these cases and provide a 30-cent tablet that can actually treat a child with roundworm, for example. And the second part of your question was around, kind of, I guess, not necessarily compensation, but kind of recognition also, of, what this caused. The greatest benefit, although unfortunately so, is the attention this has brought to the crisis there. The lack of the health workers in West Africa was tangible, on the ground. I mean, we are talking about, and we're not just talking about numbers, we're talking about capacity and capability and training and things like this. So to my knowledge, there's no structured compensation system around this. But there is, and I think this is the ultimate goal, there is a understanding and a recognition of the role that they play. Perhaps it was ignored before. As you mentioned, health is one of these industries, let's say, that is relatively ignored in national level conversations about budgeting and resourcing. But really, I think it's real now, and especially here. And we've seen as a national community as well as a global community what it means when you have a weak health workforce. And it's really it's our onus, to address that as best we can.
Let's take another question.
Yeah, you mentioned earlier SARS, and one of the things which intrigued me about SARS was that when it got into the system, it cost the global GDP roughly about 1%. Compare that with what's happened with Ebola, and it intrigues me that notwithstanding the wonderful work that's been done, it didn't catch the imagination of the markets anywhere near as imagination is the right word, but the effect of the markets was nowhere near the same. And I'm just wondering three things. Is it firstly, is it Africa? No one really cares. Is it the fact it's contagious versus infectious thing? I mean, maybe that's one of the things, the Ebola transmission. And what is the implications in terms of getting governments and market solutions and philanthropists involved, given the different effects of a SARS versus Ebola, given the fact that SARS killed hardly anybody, Ebola killed probably 10 to 15 times as many people.
So I'll start there and then turn to the panel. I think that, working on TB, we have the exact same problem, which is that it's not recognized in the U.S. as really being an issue anymore. I think you're right with Ebola that the Ebola outbreak in Africa, having followed it pretty closely as an outsider, didn't really get in the news until those patients showed up in Dallas, right? And then all of a sudden, it was a huge issue. Not the hundreds or the thousands of deaths going on in Africa, but the single patient in Dallas. And how do we bridge this gap between what's happening locally and what's happening globally to get sort of the awareness? We haven't done a good job of that, right? We haven't been able to get the U.S. population interested in a massive crisis if it hasn't affected them. SARS was, I was there during SARS, and I was actually living right across the lake in Rochester, New York. And we could not go to Toronto because everything got closed. I mean, Toronto shut down. As you said, it cost them billions of dollars in revenue in Toronto, billions. So why is that? Is there anything we can do? Catherine, do you see that changing? Michelle, do you see that changing?
I will not answer that question directly, but just emphasize that, again, from the technical side, we today have technologies that should greatly improve detection, right? And in a very, very cost-effective way. And I think among the different things that needs to be deployed or increased, in being increasingly used is that type of approach. And in terms of motivating, if you wish, the public in the developed country, I think it's a fundamental cultural question, obviously.
You have any ideas, Catherine?
Sure. I think it was brought up earlier that when diseases travel on airplanes, people get anxious. So when Ebola first moved from West Africa into Nigeria on a plane, is certainly when Europe started paying attention because there was global travel happening there. And I think just from a sort of helicopter out perspective on this kind of question, the number of planes that are going in and out of Hong Kong is a gigantic number, particularly versus the number of planes that are going out in and out of a place like Monrovia or Conakry or Freetown on a daily basis. And so I think that when the economy is reacting to signals, one thing it's reacting to is the opportunity cost and the opportunity problems. And so if you have 150 planes leaving Hong Kong in a day, and you only have 5 planes leaving any one of these other infected places, I think part of that is that the signal is just louder on something like that. Although, I mean, arguably as well, I think the fact that it's airborne would be additionally concerning. I think there's like anything, it's a totality of circumstances that leads to a certain outcome. But I think partially it's the isolation of West Africa versus the non-isolation of the places where SARS was.
Any more questions from the audience? I can't. It's hard to see, so.
Hi, it's David Evans from UNICEF. I'd just like to ask the panel, I think one of the lessons we've had to relearn again in this crisis is about the importance of aligning public and private sector communications activities. And I think there were some interesting innovations and partnerships that emerged. But don't you think we really have to find a way that part of our preparedness has to be around effective communications partnerships involving the private sector? And I'm talking about things like what to do if you become affected, what to do if your loved one becomes affected, how to dispose of bodies and so forth. I just wondered how well you thought we did on that score this time around, and whether you agree with me that maybe we should look at that when we look at preparedness going forward. Thanks.
Dr. Preddy, why don't you take that one?
Sure. I mean, I think just as you mentioned, the way of the future in this sort of global health response is going to be through public-private partnerships. And we've seen that succeed before in terms of vaccine development around institutions that are committed to vaccine distribution, Gavi, around institutions that are committed to addressing HIV and TB and malaria and things like this. And it's definitely seen as a necessity for these type of emerging diseases. I mean, we have to think even outside the health sphere in this. We can't be in a bubble, obviously, in terms of our thoughts around a response. So actually going to what Gabriella said before, is she mentioned something about wildlife conservation. Ebola is a zoonotic disease. It comes about from a spillover from animals to humans and from that interaction. And so that relates to the fields of climate change, about livelihoods and nutrition and food security, about people searching for various forms of protein, because they don't have any other access to that food source, about deforestation and expansion of humans into areas in which animals traditionally reside. So, I mean, it's just one example of we kind of have to take a step back and look more broadly, at this as a public health issue, and not just necessarily focus on the health worker response, the funding for vaccines specifically, the funding for treatments and things like this. So, and the way to do that is through these collaborations, between public industries and private industries, and it needs to be formed beforehand. It's, again, one of these things that we talk about preparedness. You had asked about priorities, when we look about financing. Every dollar you invest in preparedness and prevention pays out dividends, in response. And one of the challenges we have is that you don't see that. When something is prevented, you don't see it. Like, you don't know what could have happened. And so I think, this is the time, especially with the attention being brought to this response, is to forge those partnerships early and come up with ways that we can deal with these type of outbreaks at the beginning stages, and when they occur, and hopefully even prevent them, in the future.
So let's finish up. Yep, let's finish up 30 seconds each.
Okay.
So I want you to tell me, in 2 years, has the Ebola epidemic ended? Each personal opinion. And has anything really changed? And do we have a better international response to emergencies? Or is this SARS all over again? And China put a lot of stuff in place, but the rest of the global health community really didn't respond to the SARS epidemic in any sort of meaningful way. So where are we in 2 years? 30 seconds each.
Sure. So clearly the epidemic will have been completely controlled, which is also the biggest risk. And I think the last question was really important. And for me, the message is we should not forget the lessons we've learned. And I think some of the interaction, or all the interaction between public and private sector have been absolutely extraordinary. And we should capitalize on that and make sure it's sustainable and continues that way for the future, leading to the question of who can actually is best placed to orchestrate this to make sure it happens.
Catherine, where are we 2 years?
So I think we will be better capacitated as a global community to respond to emergencies with health consequences. Certainly, I think that the right movements are being made at the right levels to institutionalize things that would provide for that kind of capacity. We have, just as a matter of course, I am not going to say when the Ebola outbreak will or will not end, because I think that it may be just bad luck to have that conversation. But one hopes that in 2 years, certainly, that we've eliminated this outbreak, though of course eradication isn't possible because there's an animal reservoir. But yes, I think 2 years from now, we will have a better mechanism and a much more interoperational mechanism with partners, with the UN, with NGOs, with the private sector. I think it will be better. I don't know if it will be exactly perfect, but it's a learning curve for all of us over time.
Gabrielle, your crystal ball?
So I hope that we will have gotten to zero in this outbreak quickly. However, there's statistics that Ebola recurs in 50% of the communities that it's been in the past within 2 years. So I'm fearful about that. And I agree with Catherine that I think we'll be in a much better position. I don't know that we'll fully have embraced all the lessons learned.
No pessimists on the panel. Yeah. Last word.
Yeah, and just to kind of follow up on that, I mean, globally, I don't think it would have ended. And the reason is because in the last 40 years, we've had 24 Ebola outbreaks. So on average, every 2 years, we do have an Ebola outbreak. And so we need to be prepared to that and not just think about, this one in isolation. And I guess my message is, kind of the mantra of like, think globally, but act locally, because it's really at the local level that all of these innovations and activities and investments will come to fruition.
Okay, well, I'd like to thank the panel. We're out of time. Let's give a hand to all the speakers. Thanks. And thank you all for attending and asking questions. We appreciate it.